If you have it about right there, you'll be able to see the presentation and the speaker.
Which one, Heather? This one or the other one?
I unmuted myself, sorry. If right there where you have it now, you can see both the presenter and the the PowerPoint. I don't know how much the speaker wants to be seen.
Or here's all of them. Which one's better?
I think zoom in a little bit closer again. And I think, well, if it's there, then they're not going to be able to see who's talking. But I think there's probably good.
Because I don't know how this would be. Mike, just tell the code before you start, it's 1968.
What do I need to?
Just tell them that the policy you need to go for is 1968, so they can proceed. That's all I'm putting in the chat. She will, but the people that are here.
Yeah, I take mine step in this week.
So I took step in last year, and I went to that basketball. Which was the best thing I've ever
Did you take it at Silver Marketing Center? I'm Steve.
But that basketball court, I don't know if I just took a step and I was cracked out, or it was
Chilling, you're
that was spring very the best I yeah, I shit you not, that was one of the best aquariums I've ever been in my entire life.
You said something.
They had like large bass, they were just like large
Well, whenever I got here this morning, I came in on
across like a big cylinder. I don't know. You want to see some big and my mom wife was it's not like it was like the time it was like a legit aquarium and there's one basketball
it's just mine. Next month. Most of the time. Yeah. I said, yeah. She told me she was gonna do it last week.
I can hear you. It's just I can also hear a lot of the people in the back, but I can hear.
I only see the lights. It should stop.
That's pretty interesting.
For a couple of days.
I think so.
I saw
Okay, good morning. I think the first thing I'm supposed to say is that the CME code is 1968. People can get their CME credit. Good morning, everybody. Thank you for attending. I always feel comfortable when a bunch of people that know me introduce me, so I'll introduce myself. My name is Aaron Laney. I'm the EM department chair, and I'm also the program director for the EM residency here at OSU. And I'm going to speak to you guys today about EMTALA, a little like basic groundwork to understand this law. We kind of identified this need in our JV committee about some of the frustration among house staff as to how patients end up here and what is an appropriate transfer And why do we handle these things the way that we handle them sometimes? So we'll get started here. So what is EMTALA? So EMTALA stands for the Emergency Medical Treatment and Labor Act. And this was passed in Congress in 1986 as part of a bill called COBRA, the Consolidated Omnibus Budget Reconciliation Act. It's actually on every single emergency board certification test that you'll ever take. They ask what bill is EMTALA part of. And it was created to address the problem of patient dumping. And so most of us here aren't going to be old enough to remember, but it was fairly commonplace in the 80s for patients to pop up at certain hospitals, and based on their socioeconomic status or their ability to pay, they might say, hey, look, you have an appendicitis, you don't have insurance, you need to go downtown to the university hospital and they'll take care of it for you. And hospitals would actively and administratively use those turnaways of patients to protect themselves from financial loss. So really crummy thing to do. And so what this bill did is it ensured access to emergency services for all people, regardless of ability to pay. And this is probably a good point within the talk to mention. This you don't have to be an American citizen for this law to protect you. Someone can literally fly from Guatemala to the airport, Tulsa International Airport, with the goal of getting medical care in the United States. Call the ambulance when they get here, have them bring them to our hospital, and they're protected under EMTALA. We have to provide emergency services to those people. So for EMTALA to apply to a facility, you have to be a facility that participates in Medicare. I will tell you that even within Oklahoma, though, sometimes there are state statutes that kind of reinforce EMTALA for hospitals that don't participate in Medicare. We have a few hospitals in Oklahoma that are described as micro hospitals or standalone emergency departments. And these hospitals don't bill Medicare, so that's not enforced federally. That patients have to receive medical screening exam, they have to provide the services that they're able to offer, but the state makes them follow those state guidelines. So sometimes state statutes reinforce these laws. So if a hospital participates in the Medicare program, this law mandates that the hospital offer emergency services and that they must provide a medical screening exam. So this is kind of why in emergency medicine, we know so much about EMTALA, not because we're getting smarter or we like reading about laws. It's just because this really is part of the curriculum when you're trained in emergency medicine, and every single patient that we see, you're documenting as to whether or not they had a medical screening exam. So anybody that presents to the emergency department and requests care has to undergo this process. And then it's on the NIDIS is on the hospital to either determine if they have an emergency medical condition, and if they have one, to stabilize them. It's important for our OB colleagues to understand that, and most of them do, I'm sure, that this includes labor. So the purpose of the medical screening exam is to determine whether or not the patient has an emergency medical condition. HCFA, which is the federal agency that administers Medicare, Medicaid, and all of the child health insurance programs, requires that this screening exam be done by qualified medical personnel. The law doesn't say or mandate that it has to be a physician. Each hospital's individual bylaws will designate who is responsible for the medical screening exam. And not all hospitals is a physician. Sometimes it can be mid-level or other type of provider, but ultimately the physician on duty is responsible for the medical screening examination. It's important to note here that triage is not considered a medical screening exam. So hospitals that have been found guilty of EMTALA violations previously, something like this will happen. Someone will come to the emergency department with a complaint. They'll be triaged by the nurse. The nurse will call their doctor, and their doctor will say, send that patient over to the clinic, I'll see him right now. They don't need to be in the ER. that's technically an EMTALA violation because although the patient underwent triage, they never had a medical screening examination. So the federal courts have basically described that there's two components to an appropriate medical screening examination. The first component is that the examination must be reasonably calculated to identify critical medical conditions, and the exact same level of screening must be uniformly provided to all patients who present with substantially similar complaints. So you'll find that is kind of an overarching theme, and when you read about EMTALA is it's just very important that every single patient undergo the same process when they present to the hospital. You can't say, okay, my Medicaid patients go this way, my private pay patients go here, my commercial insurance patients go here. Everybody should undergo the same process. The other thing is that the medical screening examination could ultimately be wrong. So what I mean by that is someone can undergo the same process, they can undergo the medical screening examination, they can be deemed by the provider to not have an emergency medical condition and then not receive any other care and discharge. You know, this could pop up with something like a toothache. Where I trained in residency, if someone had dental pain, we went in and screened them, and then we left, and then the registration of the insurance people would come in and try and get money out of them. If they didn't pay, they would just discharge them with a list of local resources without any further care. You can see how, you know, I've been in emergency medicine long enough to see someone who presented with toothache who ended up having an MI. Ultimately, if you have a miss like that, it's not an EMTALA violation. Now, obviously it could be a malpractice issue, right? But as long as the patient underwent the medical screening exam, even if it was ultimately not medically accurate, it's not an EMTALA violation. So can the medical screening examination be performed outside of the emergency department? So after triage, many hospitals, including OSU Medical Center, we send our pregnant women with pregnancy-related complaints or after a certain gestational age to labor and delivery, which is considered an emergency area outside of the emergency department. And the exam that the patient undergoes there constitutes the hospital's EMTALA requirement for medical screening examination. These processes for taking people away from the emergency department to receive a medical screening exam somewhere else are all EMTALA compliant, as long as, again, if they apply to every patient that comes in. And we've run into issues in the past. You know, our hospital bylaws say that a medical screening exam has to be done by a licensed physician. So we've had issues years ago, like in labor and delivery, like where the patient was seen maybe by an intern or maybe only by the nurse and then discharged. Those are not legally sound practices. We have to be sure that we follow our own bylaws that describe who's responsible for the medical screening exam. So EMTALA defines what constitutes an emergency medical condition. So it's defined as acute symptoms of such severity that without treatment, the patient's or the unborn child's health is placed in serious jeopardy. Serious impairment of bodily functions may ensue. Serious dysfunction of an organ or body part is a possibility. Or if the emergency is psychiatric in nature, is the patient a danger to themselves or others? So pretty broad, right? And again, I've been in emergency medicine long enough. It's very difficult to pick out all of the potential emergency medical conditions without further testing. And so some hospitals try to, you know, at some point in the workup, stop the workup when they feel they would fair certainty ruled out an emergency medical condition and then discharge the patient and not have any more potential financial loss. But I think that, you know, certainly our department and most departments, once you get that far in evaluation, it's easier to just take care of the patient, right? Protect yourself medical legally. For women in labor, pregnant women who are having contractions, and if there's inadequate time for them to be transferred safely to another hospital, or the transfer would potentially endanger the health of the mother or the child, those are emergency medical conditions. So emergency medical conditions, pretty tough to pick out, right? So as a 4-year-old who's wheezing, is that an emergency medical condition? Maybe, right? What about an 18-year-old college student with fever and sore throat, right? Probably just a virus or a retropharyngeal abscess, right? Or epiglottitis. You know, you just can't tell right away when someone signs in. What about a 70-year-old who has a few watery stools? Could be anything, right? And you get lots of tests. So competent physicians can very reasonably disagree whether certain symptoms are acute, immediate, or serious enough to be emergency medical conditions. I mean, we can sit in here for hours and hash out details about whether or not a complaint constitutes an emergency. And unfortunately, the government agency that oversees us, they don't provide us a lot of help as determining what specific complaints constitute an emergency medical condition. They really only specifically define that psychiatric disturbances definitely do, and so do issues surrounding substance abuse. Those have been deemed sufficiently severe enough to warrant emergency medical condition. So as soon as someone's signs in with suicidality or any other mental health condition, that's automatically deemed an emergency medical condition, as is any issues surrounding substance abuse. So physicians, as physicians, when we document, we should use language that's very congruent kind of with what is described in EMTALA, because it protects us and it makes it easier for anybody, any outside observer, anybody who retrospectively evaluates our documentation to understand what our mindset was when we saw the patient. So using something like no emergency medical condition found, super simple, right? And they know that the patient was screened by a physician and we didn't think anything else was going on. This comes up a lot for us in the emergency department when people show up in police custody. So they have a policy at the city and county jail where, if someone's had any injury, any type of motor vehicle crash, whether or not the patient complains of an injury, they have to come to the hospital. When they get to the hospital, because they're not booked into the jail yet, the cost of the hospital visit is for the patient. And the patient typically says, I'm not injured. There's no way I want to pay for this. And so what do we do with those patients? So if they don't consent to a medical screening examination, then their EMTALA mandate is waived. Okay? Now you have to document that they were of capacity to refuse and that kind of thing, that they're able to make their own decisions. I mean, if someone presents with ultramental status or coma or something like that, they don't have the capacity to refuse. So then they would just be implied that they have an emergency medical condition. So again, if you do this medical screening exam on a patient and you deem that they don't have an emergency medical condition, that's when the law stops. Everything else in regard to EMTALA stops after that. It only applies from the time the patient has an emergency medical condition until that's ruled out or until the patient is stabilized. I should have mentioned earlier, and I had a boldface, but this only applies to patients who present for emergency services or who are on hospital property. So typically 250 yards is the measurement. I'm not sure from the epicenter of the campus, I'm not sure, but basically anybody that's on our property that has an issue, if someone passes out in the parking lot, they have to receive a medical screening exam if they request it. Okay, so does EMTALA require physicians to take call? This is kind of where this law kind of moves a little bit out of the emergency department and it starts to affect our physician colleagues in other parts of the hospital. This is important for you guys because regardless of your specialty, you very likely are going to have to talk to doctors who are trying to transfer you patients later. And you have to be very, very careful about what you decline when someone's trying to send you a patient. So interestingly, EMTALA does not mandate that physicians have to take call, but what it does mandate is that each hospital must maintain a list of physicians who are on call. It's vague, it doesn't say, you know, if you're a surgeon, you have to take this many days of call or anything like that. But it just says that the hospital basically has to maintain, provide, and enforce an on-call list. Whoever is on that call, on the on-call list, if their service are needed, they're expected to respond to stabilize any patient that's found to have an emergency medical condition. Well, which specialty should take call? The law states that there should be a call roster, but again, it's very vague and doesn't say specifically, you have to have cardiology, you have to have pediatrics. What they, basically, the guidance that they provide basically says, well, what service does your hospital provide generally to the public? If there is a service that you generally provide to the public, you're expected to provide on-call duties for those same services. So if you have a urologist per se, this is all hypothetical, you have a urologist who's doing a bunch of outpatient cystoscopies at the hospital. You know, every day, Monday through Friday, 9 to 5, but you don't have any urology call, that's going to be a problem. You guys understand that? So it's like those types of things that you're routinely doing, you must offer to the public after services. Those services must be identified on the on-call roster. So this is when things get uncomfortable and even get uncomfortable to talk about. What are the EMTALA requirements for on-call physicians? So sometimes, potentially in an emergency department somewhere, you could call a specialist on call and say, hey, I have this and I need you, I'm not comfortable with this patient, I need you to see the patient. And they say, you know, lots of things, lots of responses to cover. They say, just put them in and I'll see them in the morning, but maybe the ED physician is like, well, I'm not comfortable with that because I think there's a more time-sensitive issue. Or I think this patient needs to go to the operating room right now. And so it can get uncomfortable because when people are on call and it's the middle of the night, they don't like to come to the hospital. And I get it. I don't like to work nights also. So it's uncomfortable for everybody. If you're on the on-call list and you're beckoned to the emergency department by the emergency physician, you must respond. You have to call. I mean, you have to come. And if you don't, that's an EMTALA violation. It's a violation of federal law. You place both yourself personally, professionally, and the hospital in great jeopardy if you don't respond to call. So the law actually defers to the physician that has the patient in front of them. Okay, which makes sense, right? Because sometimes things are lost in translation or in communication, but when, you know, if the two doctors were standing together at the bedside of the patient, there'd probably be a lot more agreement. The burden is to actually get the on-call physician to the bedside. So if your consultant sees the patient and they believe that, you know, the patient needs this kind of surgery, which I do not do, or needs a level of care that is not provided at the hospital that you're at, then it's okay to transfer the patient to a higher level of care. You can't transfer to a lateral level of care or a lower level of care, but you can transfer to a hospital that offers a service that you do not have. Something that we could run into, and it happens with our consultants sometimes, is that the physicians listed on your on-call list may be on call at more than one hospital at the same time, which can logistically present some issues. It's completely legal, okay? It's just important for the physician to let everybody involved know that, hey, I'm on call at more than one place, and it could potentially be an issue if, you know, especially in surgical specialties, like if you're a neurosurgeon, you're doing emergency surgery on someone, and then another neurosurgical emergency, they tried to transfer it in. You're like, I'm in an 8-hour case. That person has a very time-sensitive issue that I'm not going to be able to address. It's okay to decline the transfer then, because it's a capacity issue, right? If regardless, in overcoming EMTALA, if you don't have the capacity to take the patient, you don't have to take the patient. You know, it's sometimes this can be entertaining. This has come up here. We've had a patient come in and our consultant on call would be like, yeah, I can't take care of that, send that same, you know, wherever, and they're also on call wherever, so they end up taking care of it anyway, but just at a different hospital. So further issues regarding the on-call physician's role in patient transfer. So we're obligated to accept transfers from emergency departments. Okay? If a patient is inpatient somewhere, EMTALA doesn't apply that. Okay, we should probably still take the patient if we have the capacity to take care of them, because that's the right thing to do, right? But we're not legally obligated to take the patient after they're admitted at another hospital. So transfers from other emergency departments, if the transferring hospital does not have the capability to stabilize an emergency medical condition, and the receiving hospital does have the capability. So this is pretty easy. And so sometimes we get miffed when we get patients that are on death's doorstep when they get here, like they transferred an unstable patient. That's okay to transfer an unstable patient if the hospital has done everything they could do to stabilize the patient before they send the patient. You know, it's like bad GI bleed in Fairfax, Oklahoma. They've given all the blood they have, they've given all the medicine they have, they don't have a surgeon, they don't have IR, and they don't have gastroenterology. It's literally the patient's only chance. Either be transferred unstable or to just watch them die, right? So I think sometimes we're like, this patient was too unstable to transfer, but my department works at these outlying these and they just have the resources available to them are much less than what we have here. So you kind of have to look at these transfers through the eyes of the people taking care of them out in rural Oklahoma. So like I mentioned before, and the reason why if you try to transfer to any major hospital in Tulsa, you're probably not even going to talk to a physician. Because physicians outside of the emergency department oftentimes have poor understanding of EMTALA. And this is not a ding on or an attack on their knowledge, because they're experts at what they're experts of. And generally their opinions about whether or not a patient should come are based on medical decisions, which is what we do. But EMTALA doesn't necessarily govern like what is a good medical decision. Okay? They govern what is a good legal decision that keeps hospitals open and keeps doctors from having to pay big fines. So sometimes doctors decline transfers based on sound medical decisions that are clear EMTALA violations. So some common things you may see: the patient needs to go to a bariatric center. There's not such thing in Oklahoma. Okay, like if I had a heart surgery, I would love to go. Everybody should go to Johns Hopkins or Mayo Clinic, right? You can always describe a route for the patient that is superior to another plan, but the feasibility of it, especially in real time when a patient needs emergency services, is a different issue. So like this patient's 800 pounds. That becomes a capacity issue. It doesn't matter. Are you comfortable doing a procedure or surgery on that patient? Do you want to? Do you think it's best? None of that matters. All that matters is, will your surgical table support the patient? Okay. So sometimes patients or physicians will turn down patients and transfer, and then when they're investigated, they go, well, you've done this case, the same case 30 times over the last 15 years, and then you turn this one down. So especially when you've done the case before, when it presented primarily to your hospital, you place yourself in great jeopardy when you decline that patient to transfer. If the person that tried to transfer the patient, or if the patient or the patient's family calls the state health department, it's going to be a big deal. It's going to be hard to defend. The other thing is the patient needs the fill in the blank specialist, right? No, they could potentially need ECMO, so we're not going to take it. all of the what ifisms, right? The unlikely, the single-digit % outcomes, but not the most likely outcome. The patient needs a hand surgery for a boxer's fracture, but we take care of those in our OR every day. We shouldn't be declining that patient, right? Patient needs, this is always going to trace, patient needs a trauma surgeon or a trauma orthopedist. Again, you better make sure when you decline that patient that whatever splenectomy, nephrectomy, egg slap that they needed is something that you're not credentialed to do, that you haven't been doing, because if it is, it's an EMTALA violation. So a lot of this boils down to what are you credentialed to do at the hospital? And for the attendings that might be listening to this is important for us, because I think when we go through re-credentialing, we just sign the bottom of the old credentials, and we may not go through each surgery or each procedure that we're credentialed to do, but it's actually very, very important. But administratively, our hospitals have recent issues with this because, someone gets into the twilight of their career and they're like, they really have stopped doing these procedures. Especially, procedures, if you get to be older, an 8-hour surgery, you're like, I don't do those anymore. Those are hard. Or, orthopedic surgeries where you're holding extremities up for hours and hours. You may not be physically able to do those anymore, but EMTALA doesn't care. EMTALA just cares, are you credentialed to do the surgery? If you are expected to do the surgery if the patient needs it. So when we do our reappointment, it's very important that you make sure that you're not credentialed for anything that you're either not physically able or not willing to do, or that you don't feel confident to do anymore. Sometimes there's a procedure that you've done with such scarcity over your career, you're like, yeah, I probably shouldn't be doing those anymore. You have to make sure that you're not credentialed on those. And the thing for the hospital, we have to make sure when we construct our on-call list that, maybe someone doesn't do some things, but we also have to make sure that whoever's providing our on-call duty has a broad range of capabilities for the specialty that they're representing on the on-call list. So it's super important when you apply for credentials and when you re-credential that you look real close at what you're actually credentialed to do. So why is this a big deal? Well, because the penalties for this are tremendous, and the ultimate thing for the hospital is all about Medicare. Okay. You guys remember at the beginning, I said this law only applies to hospitals that participate in the Medicare program. Well, the ultimate penalty for an EMTALA violation is they take that away. They say you can't participate in Medicare anymore. And a lot of times, the state agency can follow suit with whatever state healthcare program that they're administering, like Medicaid. So can you imagine at our hospital what it would mean if we all of a sudden could not bill Medicaid or Medicare? We'd be closed in a few days. Okay, those are our patients. Those are the people that we love taking care of. But if you don't care about the hospital and you don't care about the university, personally, there are really big monetary penalties if you are found guilty of an EMTALA violation. So for the individual, there is up to almost $120,000 per violation. I make a nice living, but I sure would hate to have to pay $120,000 just because I didn't accept a transfer or provide emergency care to a patient. And it's the same for a hospital our size, so over 100 beds, almost $120,000 per violation. So from a monetary standpoint, it's a very significant thing to incur. So this is kind of, as mentioned, the ultimate would be taking away our ability to participate in the Medicare program. Now, private citizens, so this isn't, the federal office of the Inspector General, private citizens who are harmed by a physician or hospital's failure to provide stabilizing treatment can always file a civil suit. And they have the same, array of personal injury law that they're protected by as well. So if you are found guilty of an EMTALA violation, it's very, very likely that if someone sued you for personal injury, you're also going to be found guilty. So you can kind of just write the check on that one. So just so everybody knows kind of what the expectation is here and what the bylaws in our hospitals say in regard to consultation in the emergency department. So that is, EMTALA mandates that we have to have these bylaws to facilitate on-call duty, on-call scheduling, on-call responsibility. So what is that duty actually here? Because I think it's tough for a lot of our house staff, because especially our surgical colleagues that are, maybe ortho and ENT, where they're at several hospitals at one time on call. For emergency consultations here, it's expected, the bylaws say that you have to evaluate the patient within 30 minutes of being notified. So emergency is going to be, a ruptured AAA, a gunshot, something that's the patient's going to at high risk of death very quickly if not addressed. This is probably a good time to tell you too, is that the resident's contact with the patient or the resident's response to the consult does not substitute for the attending's on-call duty, okay? Now, we're a teaching hospital and that's how we function, but when there is a disagreement or if something is very time sensitive, whoever is on the call schedule is actually the person that's responsible for the consult. So this is not something typically that we have an issue with for emergencies, because that's usually the things that we're able to all agree upon management of. It's more like the urgencies where there's kind of more than one way to skin a cat. But even for EMTALA, it's the middle of the night, emergency medical condition, and the resident responds and says, okay, maybe this patient can be discharged. And the ED attending is like, I'm not comfortable with that. For that patient to ultimately be discharged, the patient will have to be seen by the person who is on the on-call schedule. And that's not the resident. So the resident consult, the resident care does not substitute or meet the EMTALA requirement for the person on the schedule. So 30 minutes for emergencies, everything else is 60 minutes. Okay, and whether it's deemed emergent or urgent, again, that decision falls upon the ED attending, the person who's actually looking at the patient. So that should kind of cover everything from a legal standpoint, but I think for us, and Dr. Alex, Dr. Cook, Dr. Gerhard, the people that have been around here long enough, there's even a bigger issue, like where we, the guys that have been through hard times here, the guys that looked at these headlines and the Tulsa world every day, we understand how fast referral sources dry up, okay? I've been here 17 years, roughly, and I can remember when the daily census here was over 150 patients. So like when Dr. Cook was a resident, when Dr. Som was a resident, 150 patients daily census every day. We have, we probably have, I don't know, a third more residents now. And yet our census is like a daily census is like a third less. We used to do way more with way less. And that's not like, oh, I used to walk uphill to school both ways. Shut up, Homer. I get it. But what we're trying to do here for the long-term stability of the hospital, for the long-term stability of our residency programs and the university, you guys have probably seen the architect renditions. We're building a huge medical district here, and we can't do it without patients. We, for years, Dr. Blankenship and Dr. Som would get in their car every week and drive to one of these rural hospitals and say, we want every patient. We want the good, the bad, the homeless, the affluent. We don't care. We want bodies in beds. We want patients. We got students and residents to train. Okay. I'm almost 50. When I have to get up out of bed in the morning and drive to Stillwell, Oklahoma to work a university contract to try and guide patients back here, honestly, it pisses me off to hear house staff complain about patients because I'm actively trying to get those transfers here. And that's why it's important for me to explain to you guys, like, if we can take care of them and the other places can't, we legally have to take care of them. But also, so in 2008, end of 2008, beginning of 2009, our hospital was closed. We were done. We were dead. I'd already been reassigned to St. Francis. Our residency program was moving to St. Francis. All of our department's business was posted in the newspaper. Anyway, how do these people even know? This is wild. They're not even sitting in the meetings. We got through this, obviously, and then we have the OSU Trust that kind of governs the hospital now. But during this time period, all of our referral sources dried up. So even when we got through this, we had no patients for a long time. Okay, we had surgery residents coming down to the emergency department going, hey, you want anything that's kind of surgical, please, I need cases. Okay, so we need these patients and we have to cater to these hospitals in rural Oklahoma. If they need our help, we need to be willing and we need to make it seamless. You know, that's why when I work, when the guys in our department, we have like 7 or 8 rural contracts. When we work in those contracts, the patients, the places that we send patients are places where we can make one call. We get a quick answer, yes or no. Do you have capacity to take care of the patient? If it's yes, we send it. Okay, and then that's why here, the specialists no longer get the transfer calls unless there's some kind of question. You know, all of it comes through the ED attending. And the answer is almost always yes. And that's why if we can take care of the patients, we have the capacity, we have a legal requirement to do it, and it's just good for our mission. So I hope we never see these days again, but when I hear things like this is an inappropriate transfer or this is an inappropriate consultation, I kind of go, man, there's a big knowledge gap there. And that's why we identified this need in GME and we wanted to bring this to you guys. We need patience. The more we can get, the better for everybody involved. Thanks for your attention. Anybody have any EMTALA questions? Awesome, thanks.
Stay there.
Okay.